We have a tort liability system, or a system of personal injury litigation, for three reasons. The first is to provide compensation to people who are hurt because someone has deviated from a standard of care that we've deemed to be important to adhere to. The second is to provide these people with not just money, but some kind of broader notion of corrective justice, meaning we have the system to make people whole. You can do that with money, but also in other ways. For example, by allowing people to tell their story, to be heard, and to hold others accountable and receive other kinds of restitution or apology from them. Corrective justice can also be served through civil litigation. And the final purpose, and actually the purpose through which most plaintiffs' attorneys would justify keeping this system, is deterrence. We think that having a tort liability system that revolves around the concept of negligence encourages providers to avoid substandard care, meaning care that dips below what we consider reasonable or customary care to be. In other words, providers are deterred from making poor decisions that result in foreseeable and avoidable accidents. So compensation, corrective justice, and deterrence are the raison d'etre of our court system. So how well does it do at serving these functions? Let's take a look. First of all, compensation. Over the last 30 years at the Harvard School of Public Health, we and other colleagues have been involved in a series of studies that have really revolved around the epidemiology of medical injury and malpractice claiming, and have asked a question: who's getting into this system as a claimant and who's taking money out? Here's what we've learned. If you are seen in a hospital in the United States, you have about a 3 or 4% chance of being hurt by the medical care you receive, and about a 1% chance of being hurt by negligence, which means care that dips below the standard of reasonable or customary care. So that 1% of hospitalizations gives rise to a potential pool of what we might call valid malpractice claims. They're valid because they involve an injury that's due to medical care and that is in fact due to negligent medical care. What we've learned is that only between 2 and 5% of these people who have a valid claim will ever file a claim. 2% if you look at all of them, 5% if you look just at the people who have actually quite serious injuries. That's a really low number. So if you ask the question of how well is the tort system working as a compensation mechanism, you look at that and you say that's lousy. 95 to 98% of the people who are entitled to money under the rules that we've set up never even try. Now, what happens to those who do try? Well, the problem from physicians' perspective, of course, is that layered on top of all these valid claims are a bunch of other claims that have no merit or are of uncertain merit, primarily because we can't figure out if there was negligence or not, or it seems pretty clear actually that there wasn't any negligence. When we've looked at closed claims across a variety of insurers, here's what the numbers look like. Less than half of the claims in the malpractice system are what we would call clearly valid claims. Interestingly, another quarter of them, even at the end of the litigation, when you have every bit of knowledge you're going to have about that case and you ask experts to review it, even then, in a quarter of the cases, we have to say, it's a close call. We don't know whether there was negligence in this case. And then in about a third of the claims, we'd call them frivolous in the sense that we couldn't find any evidence of negligence in those cases. So who takes money out of this system? Well, more bad news. The answer is people take money from all three of these groups. You have a much higher chance of getting paid in the system if you bring a genuinely meritorious claim. But even if your claim is in what we might call the clearly non-meritorious category, you still got a 1 in 4 shot of taking money home in a settlement. And that's what's really dispiriting for doctors. So the second reason why this system underperforms as a compensation system is that it makes mistakes in directing money to the right people. Again, thinking about the rules that we've set up for the system, which says you only get money if you were injured by a negligent act of care. Drilling down on these data a little bit more, this is from the Malpractice Insurers Medical Error and Prevention study that we did here at Harvard and that was published in the New England Journal of Medicine in 2006. We found that actually a higher proportion of claims than was conventionally thought at the time did involve a medical error, about 63%. So the notion that the system is flooded with totally frivolous claims is a little bit overblown. But when you look at the bottom row of this figure, you see that in about a quarter of the claims, the system makes a mistake. That is that people who don't have a claim that was due to, or an injury due to error, receive a payment in the system about a quarter of the time. And what's even more disturbing, frankly, is the other yellow box, that people who are entitled to money because they were the victim of an error and had an injury get no payment in about a quarter of the cases. And it turns out that in terms of the size of these groups, that group is much, much larger than the group in the 26% or 28% who didn't suffer an error and got a payment. So the major problem in this compensation system from a scholar's perspective is not merely that people are taking money out of it when they shouldn't, but rather even those people who scrape their way into the system, who are in the 2%, a lot of them don't recover money when they should. So from a compensation perspective, the system is not doing a great job. And to add insult to injury, we spend an enormous amount of money figuring all this stuff out in the system. Estimates are in the 50 to 60% range in terms of the percentage of a doctor's insurance premium dollar that go to overhead costs in the system, lawyers and courts and insurance fees, just to figure out who's entitled to money. So from a compensation perspective, we're not doing great. How about corrective justice here? Now, there's an argument that even if we don't do a great job of giving people money, we could give them other forms of corrective justice and still make them feel as though they've been made whole. And when we think about claimants and malpractice claims, there's a pretty good argument they're getting some forms of corrective justice. They get an opportunity to learn what happened to them. And in fact, many people still find, even in today's age of greater transparency around errors, that doctors and hospitals are not willing to tell them what happened to their loved one until they file a claim. They also get their proverbial day in court to tell their story, to tell the doctor how his conduct impacted them, perhaps to receive some other form of restitution, and perhaps to inflict a penalty on the person who has wronged them, which is probably not economic. Doctors don't generally pay the cost of their own claims. They're very well insured, but is reputational and psychological. But even for claimants, the system fails in a number of ways. One is that the vast majority of settlement agreements are made without an admission of liability. So that moment that a claimant dreams of where the doctor accepts responsibility for what happens, for most people never comes. It is simply described as a way for the hospital and doctor to get rid of the lawsuit. And most settlements are confidential. So the idea that the person gets to sort of publicly proclaim wrongdoing in the case also is more fiction than fact. But the major problem with corrective justice in our system is, again, that the overwhelming proportion of people who are injured by negligence never access it in the first place. Finally, what about deterrence? Does this system make healthcare safer? Well, there are a few reasons to be skeptical on theoretical grounds about its deterrent value. We know from research in areas like criminal law and compliance with other kinds of laws that deterrence is a function of three things: the severity of the sanction you get if you don't comply, the swiftness with which that sanction is visited on you, and the certainty with which you're going to be sanctioned. And the tort system does not do a great job on these fronts. Another problem is that physicians have difficulty understanding what it is that the law is asking them to do. What does negligence mean? What does reasonable care mean? These are not rules that are set out in a book for physicians to understand. Again, even at the end of litigation in the study that we conducted, it was often not clear whether negligence had occurred. So if you want physicians to adhere to a standard of care, you need to tell them what exactly that is, and this system doesn't really make it clear. It's also not clear how likely they are to be sued. In fact, doctors tend to overestimate that probability wildly. And so all this uncertainty really interrupts the possibilities for deterrence. And then there's another problem, and that is that most physicians don't pay the cost of their own malpractice claims. They have generous liability insurance, and it's not very common for the price that they pay for that insurance to go up or down a lot according to their claims experience, particularly if they've only had one or two claims. Then there's the problem that most of the time when they commit negligence, there's no economic sanction because there's no claim. So it's not like when you speed and you know you're going to get a speeding ticket if you zip past a cop. In this system, there is no cop almost all the time. What do we know empirically about deterrence? Well, not very much. It's actually surprising how little we do know. There have been quite a few studies of the quality of obstetrical care, and the bottom line is we don't see any improvements in the quality of care that we can associate with a physician or a hospital having been repeatedly subject to malpractice claims. There doesn't seem to be learning going on in the system. And when the Harvard Medical Practice Study, which is one of the biggest studies of malpractice claiming, looked at this issue using tens of thousands of malpractice claims, in most of the models that those researchers conducted, there were not any significant associations between the quality of care and patient outcomes and their malpractice experience. So there's very little reason to think that deterrence happens systematically in our system. So overall, if I was to give our malpractice systems a grade, a report card, based on how well it was doing what it was supposed to be doing, here's what it would look like. Nothing a parent would be too proud of. It does a very poor job of getting money to the people who deserve it. We spend enormous amounts doing that. Corrective justice happens for a few, but not for most people in this system. And in deterrence, we have anecdotal examples of where care has gotten safer, but at a population level, very little evidence that we're buying a lot of safer care for our dollars here.